Thanks, Ursula. Oh, you're right, those lights are very bright. I'd first like to start by acknowledging the traditional owners on the land in which we meet today and pay my respects to elders past, present and those in the room. So what we're actually going to do this afternoon is tell you a little bit about what we've been doing at DHSV in relation to value-based healthcare and hopefully tie together some of the things that you've heard about today already. Some of my slides will look very, very familiar for those who've been paying attention. So, what have we been up to and why? So we at DHSV have 4 key strategies that we're trying to achieve. We're trying to improve health outcomes, we're trying to improve the experience, we're trying to be global leaders with our local partners and be a great place to work and a great organisation to work with. The reason that we're using the value-based principles is they actually align very nicely with enabling us to do that. This slide will come as no surprise to you. This is the value agenda, as we've been talking about all the way through this morning. So we've been talking about measuring outcomes that are important to patients or to clients and at what cost. So how can we actually make that value equation work? So at DHSV, we took Porter's model that you've heard about this morning. You saw a slide that the Minister put up this morning with actually might have been the person from Safer Care Victoria that put up a model. That was about 4 versions ago. At DHSV, we believe in changing things and moving quickly and rapidly, so this is the latest version of our model. Or actually, we've now decided to call it a framework. So this is what we're actually using to enable us to implement value-based healthcare. It has consumers and our workforce in the very centre of everything that we do. And you've seen, if you actually went to one of the workstations that Joe was at earlier on today and talked about how we actually co-design our work, it's a really important part of what we do, not just with our consumers but with our staff. And as you've heard also earlier today, this has to be clinician-led. We can't do this to clinicians. We need to do this with clinicians, which I'm sure you will all appreciate. So this is our latest wheel of cheese. And it talks about not only the models of care and how we're actually implementing those, but all of those support systems that need to be in place to enable us to do this transformational journey. So what we've done at DHSV is started a proof of concept about 6 months ago. So we started on the 1st of October and we looked at how we would actually do a model of care within our general dental clinic. And for those of you who've been at some of these presentations before, you know we've been doing this for a while. So we developed a model of care that actually, again, put consumers in the centre of all that we do. I'm going to show you a video in a little minute which actually brings that to life for you so you can actually see what the difference is in a clinic situation. So the model of care we've been running in our general care clinic since October, and so we've actually achieved a few things, which is really important. We've actually been able to increase the amount of preventative work that we're doing, which was one of the key principles in the value-based model. We've actually been able to reduce our failure to attends. Now, we haven't reduced failure to attends overall. What we have reduced is our failure to attend in clinic. So we still have about that 16-17% failure to attend rate at what we call our introductory session, but that's a group session that's run by 2 of our staff and can be between 10 and 15 people. So if one person fails to attend in that space, it's nowhere near as expensive as if somebody fails to attend a clinic appointment, which is half an hour and it's got 2 people and our administrative staff, etc., etc. So it's not that we're actually reducing the failure to attend overall, but we are reducing that clinic downtime, which is really important from an efficiency point of view. So what have we learned? We've learned that the rapid assessment tool that we talked to you about in previous occasions doesn't actually work. It actually is only accurate about 50% of the time. So we've actually figured out that we needed to change that. So we're in the process of, we're about to start trialling our new tool, which is called an oral health questionnaire. Very, very fancy. So we're actually going to start trialling that as of probably next week or the week after. What we also realised is that we thought there were 3 types of clients. We thought there'd be people at very high risk, people at high risk and people at low risk. What we have figured out is that actually with the group that we've tested, which is basically people off our wait list, you're either at high risk or you're not. So we're actually changing that pathway as well. The other thing that we've learned, and this won't be a surprise to anybody in the room, considering we figured out it takes 17 years to change anything in health, is that behaviour change is very, very difficult. Our clinicians are used to doing things in a certain way. They have a muscle memory and they have a process that they've been going through for years in clinic. And actually getting people to do that in a different way is actually quite difficult. The other thing that we have been doing is we've actually been measuring outcome. So you've heard about ICHOM. So we have an ICHOM data set, and you heard about how we spent 2 years developing that data set. So what we've been doing is actually putting that data set into play. So we actually ask all of these questions to our clients before they actually come into clinic, and then we're going to re-ask those questions again at the end of their course of care. Our plan is also, so part of the program is that we will check in and check up patients throughout their lifetime, is to continue to monitor these outcome measures. At the moment, we have 23 questions. And as you heard from Jackie this morning, it started off as 123, so we think we did quite well to get it to 23. But we think that that's still too many. So part of the research that we will do is how do we actually find out which of those questions actually adds value, which of those questions are most important to our clients. The other things that we ask are the usual things around demographics, general health questions, those sorts of things. And we also look at complications, so those clinical outcomes as well. So what does it look like in real life? So we spent a bit of time in the last couple of weeks making this video, which actually brings our model of care to life. So I'd like to play that for you now. It lasts about 10-12 minutes, so buckle in. It's going to be an exciting ride. So I'll get the guys to play it. Dental Health Services Victoria is moving towards a new way of working, using the principles of value-based healthcare. The new model focuses on prevention, early identification and minimal intervention, which supports people to self-manage their own oral health. This new model ensures our consumers are supported throughout their lifetime. It's currently being tested in our general clinic at the Royal Dental Hospital of Melbourne. This video has been made to bring the new way of working to life, to help people understand how value-based healthcare is being implemented at DHSV.
Hi, my name is Sam. I'm from the Royal Dental Hospital of Melbourne. You're on our general waiting list and I'm ringing to invite you to start care.
Where did you say you were from?
The Royal Dental Hospital. And I'm ringing to discuss you starting dental care with us.
So this is about my teeth.
Yes, that's right. First, I need to check, do you still require dental care or have you had treatment somewhere else?
Yes, I still need to see the dentist.
Great. I just need to check some details and ask you a few questions first. Is that okay?
Sure.
So I'll just check some basic information. Can you tell me your address?
During first contact with clients, we ensure the client does not require emergency treatment. Those clients who do are triaged for emergency. The next stage is to make an appointment for an induction session and to collect information about the client's oral health. The dental health questionnaire, which is asked over the phone, includes demographic information and is also the first time we collect the patient-reported outcome measures. DHSV has worked with the International Consortium on Health Outcome Measure to develop a set of questions and assessments to measure oral health outcomes. The client's response to the dental health questionnaire identifies their risk and need for dental health care. It determines how soon they need to be seen. For those with high needs, this would be within 3 months, and for those without high needs, this would be within 12 months.
The next group of questions are to assist us to understand the state of your oral health. It also helps us measure the outcome of your care. We can also use them to help track your improvements over time. So, how is the health of your mouth, teeth and gums? Would you say it is very poor, poor, fair, good, very good?
I'd say poor.
How often have you felt embarrassed, smiling, laughing and showing your teeth because of problems with your teeth and gums? Would you say never, hardly ever, sometimes, fairly often, very often?
I sometimes feel embarrassed because of my missing teeth.
Do you use any tobacco products?
No, I don't smoke.
How often do you drink alcohol? Never? Monthly or less? 2 to 4 times per month? 2 to 3 times per week? 4 or more times per week?
Oh dear. At least 4 times a week, I'd say.
Okay, thanks for answering those questions. We'll ask these again throughout your care to see how you're improving. The first session you'll attend is an induction into dental health services. It's a free, small group session where we provide you with some information on the care we'll be providing for you, as well as some education to assist you to look after your mouth.
So I won't be getting any treatment at the first visit?
Well, the first visit is to make sure you know what to expect when you receive care with us and to get you ready for treatment.
Oh, okay.
Just to confirm, your induction session is on Wednesday the 10th at 10 a.m. We'll send you a text reminder a few days before. If you're unable to make it, please just give us a call and we can book a different time for you. Is there anything else you think we need to know or that you're worried about?
Oh, I'm very nervous about visiting the dentist. My mother recently had all her teeth taken out because they were so bad, and I'm scared the same thing's going to happen to me.
Right, I see. Look, thanks for sharing that information, Thea. And we'll make sure the clinical team knows so they can support you as much as possible.
Induction sessions are free for clients and they are conducted in small groups of 10 to 15 people. The main purpose of this session is to provide clients with information on how their oral health journey will progress and the importance of their commitment to self-care, and to provide them with education and support on their self-management journey. These sessions can be tailored to specific groups, for example, provided in different languages or with an interpreter, or specific groups such as smokers or people with diabetes. Thea was greeted by Sam, the patient liaison officer, and was provided with a medical history form to complete. The purpose of today's visit is to review Thea's history and patient-reported outcome measures, to work with her to develop her oral health goals and ongoing treatment plan, and to complete a comprehensive examination.
Hi Thea, my name's George. I'm a dental assistant and an oral health coach. I'm going to be supporting both you and the oral health therapist today while you're in the chair. A little later on today, I'm going to help you to develop some dental hygiene goals and support you in meeting those. This is Thea.
Hi Thea, my name's Natalie. I'm your oral health therapist and I'll be doing your oral health checkup today.
Hi.
Please take a seat. So we've had a look at the questionnaire you completed on the phone with Sam and the medical history you just filled out in the waiting room. So Sam told us that you're nervous about dental visits and you're worried about losing your teeth. Is there anything we can do now to make you feel less nervous while you're here today?
I'm okay at the moment, but if I need a break, can we stop?
Sure, all you need to do is let us know or raise your hand if I'm looking in your mouth and you can't speak, just like this. Both George and I will be keeping a close eye on you so you can stop us at any time.
Okay, I think I'm ready to start.
Great. In your questionnaire, you said that you've been having trouble eating certain foods and you described the health of your mouth as poor. Can you tell me some more about this?
Yeah, sure. I have had to stop eating nuts and some other hard foods. I have trouble chewing because of my missing back teeth, and there are some loose ones, and I'm afraid if I chew something hard, I'll lose them. I have trouble brushing my teeth. I can't brush them like I used to because of my sore wrist. But I don't know if we can do anything about that.
Thanks for that, Thea. Your form here says that your most important oral health goals are to keep the rest of your teeth and to be able to eat normally.
Yeah, that's right. I'd love that.
Let's get you comfortable and we can start the oral health checkup. Are you okay to lie back?
Yes.
And remember, you can stop us any time by raising your hand. I'll explain as we go what I'm doing.
Natalie has conducted the examination and realises that dentures may be required to achieve Thea's goals, and that one of her teeth is loose and may require extraction. She calls the dentist to support the completion of the comprehensive examination and the development of the care plan.
Hi Tia, my name is Anno. I'm a dentist. Natalie has called me in to have a look at your mouth and check that wobbly tooth, and also to go through some options to replace your missing teeth. So Tia, good news is that there's nothing that needs urgent attention from myself or for Natalie at the moment. The wobbly tooth is okay to leave right now. I don't think we need to remove it. I do agree that dentures will help you achieve your oral health goals. However, we need to improve your oral hygiene first before we look at going down that path. Is it okay with you?
Yeah, sure.
Okay, perfect. I'll hand you back to Natalie. Have a nice rest of the day, Tia.
Now, the best thing you can do right now, Thea, is to work with George as your oral health coach to improve your oral hygiene. Now, George, I think the most important thing for you and Thea to work on is her cleaning technique, keeping in mind her painful wrist at the moment. Also, given that Thea says she drinks alcohol with dinner every night, a conversation about the potential risks of alcohol consumption might be beneficial. Before I do your filling and we refer you to the prosthetist to make your dentures, it's really important that your oral hygiene is in a good state. This will help you to keep your teeth for as long as possible and make sure that the filling and the dentures last. Your management of your oral care is the key to making this happen. How do you feel about that, Thea?
Yeah, it makes sense to me. I know I have to be responsible for my own teeth.
It's okay, Thea. I'm here to support you through this. Let's head up to the coaching room and get started. I've got some great resources for you to take home too.
The purpose of the coaching session is to define the client's oral care goals and to support the client with behaviour change. The number of coaching sessions and the time it takes to complete these is dependent on the behavioural interventions required and the goals the client is wanting to achieve. The coach reports back to the oral health therapist or dentist on the progress the client has made in achieving their oral health care plan. DHSV understands not all clients have the motivational capacity to change their behaviours. We aim to enlist the support of family members and carers to provide clients the support that will best give them the opportunity to improve. If clients are unable to improve their oral health care practices, the oral health therapist or dentist is unable to progress to more definitive treatments, as this would represent low-value care. Under these circumstances, general care will be discontinued until a time when the client is better able to manage their own oral care needs. The client is advised that they can attend emergency care if required or if they have a problem, and they're welcome to come back into general care at a later date.
Hi Thea, it's great to see you again. George tells me you've done really well improving your oral hygiene. That's great. So how's the new brushing technique going?
Yes, really well. I can brush regularly without hurting my wrist and use those special little brushes for in between my teeth. And I've really learnt a lot from George. I'm even having a couple of alcohol-free days a week.
Oh,
so
great.
all's good.
Great. So to recap, last time we met, the plan was to do a filling and to get you the dentures. Is that still what you want?
Yes, that'd be great.
Well, I can do your filling today, and I've checked with Anu, the dentist you met last time, and she's happy now that your oral hygiene is up to scratch to proceed with the dentist. So we can now refer you to the prosthetist to start working on your dentures. There we go, that's all done. You did really well today, Thea. You didn't seem nervous at all.
Actually, I felt quite comfortable. Everybody explains really well what they're doing and why. And I think because I've been involved in making the decisions, I know what's going to happen next.
That's great to hear. Okay, Thea, we've made the appointment to start your dentures. Sam will give you the details. I don't need to see you in the clinic again for another 12 months. However, George will check in with you in about 6 months' time. He'll ask you the same questions about your mouth that we asked before so we can see how you're going. However, if you have any trouble with your mouth in the meantime, here's the number you can call so we can help you.
At the end of the course of care, the client's caries risk and periodontal risk are reviewed. This information, combined with the information from the oral health coach and the client's oral care practices, determines the level of ongoing support required. At this time, those who require more support will be provided with regular check-ins every 3 months. Those requiring moderate support will have a regular check-in every 6 months, and those demonstrating good oral hygiene behaviours and self-management will have a check-in every 12 months. Clients will also have regular in-chair checkups, either on a 12 or 24-month basis, depending on their ongoing risks and needs. This is our current plan, however the pathways have not yet been fully tested. The patient-reported outcome measures questions are asked at check-in and check-up to enable DHSV to track changes in the oral health outcomes of our clients. DHSV is striving to improve clients' outcomes across the ages and stages rather than continuing to provide short-term fixes. I'm hoping that gives you some indication of what it is that we're trying to achieve at DHSV. One of our team members, Aisha Mansfield, who's one of our coaches, is actually going to give you a bit of a feel of what it feels like to work in that space in this new way of working. So I'll hand over to you, Aisha.
Thank you, Sue. So, hello, good afternoon. And as Sue mentioned, my name is Aisha Mansfield, and I'm a dental assistant and an oral health coach at the dental hospital. As an Aboriginal woman, it's really important to me that when I come onto somebody else's land, that I acknowledge the traditional owners of the land on which we meet today. So, in saying that, I'd like to pay my respects to the ancestors and elders, both past and present, as well as their burai, which are their children. And we thank them for allowing us on their land today. I'd also like to acknowledge any Aboriginal people that might be joining us for today's conference as well. So as Sue mentioned, I'm going to talk you through a little bit about what it's been for me as a coach implementing value-based healthcare into the dental hospital. Dr. Zoe Weiner asked this morning, whose evidence matters? So I'm hoping to be able to provide you with an example of my experience, as I said, as a coach, implementing that value-based healthcare. The most exciting change that I've noticed as a coach is the relationships that we've been able to form between the clinicians and the clients and their families as well. While implementing value-based healthcare, these relationships have given clients and their families the opportunity to participate, be involved in their care, and therefore be able to reach their own health outcomes. This has meant that as a coach, I'm able to work with these families, support them, as well as working with clinicians to make sure that these outcomes are really where clients want to be. I'm really excited to see what happens further with value-based healthcare, and I'm really excited for the coaching role to be able to work with those clinicians, as I said, overall to be able to improve these health outcomes for clients, which is what value-based healthcare is about. I might give it back to Sue, and of course I'll be around to answer any questions for those that might have any as well.
Thanks, Aisha.
Thank you.
That's us.
Thank you, Tag. All right, Sue, there you go. That's all right. Thank you very much. And Aisha? Okay, we get the formal bit so nothing gets fumbled, obviously. We do have a couple of minutes for questions. Excuse me. So if anybody has a question, we get the microphone and I'll clear the frog that's found its way into my throat.
We've stunned them into silence again, Aisha.
Can't see you.
It's our new party trick.
Sorry, me. Sorry, apologies. Colleen.
So usually at the first coaching appointment can vary from 45 minutes to an hour. That first coaching appointment allows for us to meet the client, get to know their social habits throughout their life, and then start to work with them on their current oral health program and what they're currently doing, and then we can start to make those changes. So starting with about an hour, but again, that can depend on the individual. I've also personally run a session with a family of 8. So it was mum, dad, and 6 children. And we were able to have this family for about 2 hours. And in this session, we spoke with the children aged from 1 year old was the youngest, up to 14. So we were able to talk to them about their diet, the things that they like to eat and to do. And that gave us a sufficient amount of time to kind of have those conversations with the parents as well as the children as well.
Any other questions from...
Hi, sorry. Hi, it's Felicia from Link Health. Thank you for your presentation. So could you please outline how this model of care is going to align with the business rules and the waiting list model at the moment? Thank you.
It doesn't. That's the joy of being a pioneer. At the moment, it doesn't really align with the current waiting list policy. It doesn't align with the funding model. It doesn't align with how you actually, I guess, our priority groups as well. So the model, basically at this point in time, we're testing it to see how we can align it. But at the moment, what we're looking at is something that's completely different to most of the current policy that we're working with. Our next step into the next iteration of this is going to take it out through the rest of general care, and part of that will be looking at those priority groups. So how do we actually manage that policy through value-based healthcare? So we'll get back to you on that one.
Any other questions?
Hi.
Yep.
Oh,
One in the front.
hi, I'm Ramini from Monash Health. Just on the video, the dentist came into the examination room. So do you expect the dentist would be available on the examiner day without having a patient load? That's one question.
So at the moment, we don't actually have a floating dentist who can just wander in. We think that if we get our ratios right, we should actually be able to have a floating dentist working with a group of oral health therapists and junior dentists. We're just not really sure what that number looks like. So that will be the next piece of testing that we're going to do to see if that's actually financially feasible. And does that actually give job satisfaction for our dentists?
Sure. The second question is just about the criteria that you use when you're telling patients that you're not going to continue their general treatment. What measurements you're using so that it'll be consistent by all the providers rather than its objective?
That is currently our work in progress.
Hello? For the oral health coach, have you been seeing much improvement with the patient's oral health? Are they complying?
So from a coaching perspective, I've noticed right from the start, if I can, a little bit of reluctance coming into the hospital because it's likely that they've been on a waiting list. But being at that first introductory session where we introduce the service that we're going to be providing to the clients and their families, and we use that session to improve the health literacy and the service literacy. So we use this session time to be able to kind of get them on with us, and so that is the behaviour change as well. So getting them to understand that it's not just us providing a service for them, but them coming on board. And I think that has been the biggest change that I've seen for clients. And then it's kind of gradual in the clinic as well, because they've already been on board right from the start.
I have a question, sorry. Over here?
Time for one, just
Oh, on the
one more
stage
question.
right. Hi, Catherine Cummings from Eastern Melbourne PHN. I'm just wondering, I know it's early days, but has there been any consideration for involving GPs or, I guess, a primary care kind of aspect?
Yes, absolutely. So one of the parts of the wheel of cheese, if I can go back, maybe I can't, is actually how do we integrate this across other healthcare settings. So not only how do we integrate it across Dental Health Services Victoria as a whole, but actually how do we integrate with the acute health sector and the primary health sector as well.
Okay.
Just a question for the oral health educator, sorry.
Oh, sorry.
That's our last question.
Is there a training program that you have to undergo to then proceed to be able to educate patients and do it adequately? And then also, if you do find something that is concerning, is there a system that they go back to see either the oral health therapist or the dentist to get treatment actually done, or is what's the sort of routine that you'd go through?
Sure. So I suppose the criteria for a client coming into the coaching is, if I'm unsure of something as a coach, we work in the clinical team, so with our therapists, with our dentists, and that is our support network. So we're able to work with them about our clients. So that's about the support in the clinic. In terms of starting as an oral health coach, I personally completed a Certificate 3 in dental assisting and then went on to do the Certificate 4 through RMIT. In terms of value-based healthcare, the proof of concept team have gone through many different training modules that we've done in terms of motivational interviewing. We did the Flinders University training. So there is other parts of training that we've used at the dental hospital to expand our knowledge and to make sure that we're going to be able to meet all of those clients' needs as well.
The other part of doing the proof of concept is to test what type of training is actually required for our clinicians and our